I got to put the story so you tell it right. Nothing worse than somebody tells it and they can't remember. We're at the Rainforest Cafe on the Riverwalk with a bunch of 8th grader girls for my daughter's birthday. And there's like 10 of them. But I'm sitting close and I can hear their conversation. And I fell out of my chair laughing at what they said. I mean, I didn't mean to fall out of my chair, but I did. No, I wasn't drinking. But it was so funny, and you may not find it as funny as me, but most people do. And I'm sitting there, I hear this conversation going on, and they're ordering. They're going around taking orders. And this girl orders her food, and this girl looks at her, and she orders something that didn't have any meat, and she didn't eat meat or something. The funny thing is, when she's at my house, she always eats bacon like crazy. Anyway, I hear her go. She orders, and this girl looks at her and goes, "Are you a veterinarian?" And the girls reply, "Do I look like I've ever been to war?" Now you see why I'm glad I don't like you, because I fell out of my chair. Do I look like I've ever been to war? Kind of like learning terms in Anatomy 1 sometimes. Okay, so as I was saying, regional anatomy. I keep focusing on that because I think it's a better way to do it than study all the arteries in the body. The way we do it, like the upper extremity always says, the best example, because we're going to study by compartments. And we're going to learn what's in those compartments, as in the arm versus the forearm, anterior compartment of the arm. And then we'll look at the muscles, the nerves, main vessels. We're not going to get all off into small vessels. As we go through this, for those of us who've studied muscles and looking at, you always study origin, insertion, action, innervation, and depending on your level, sometimes blood supply to that muscle. I took out, we are going to go through every muscle in these next 3 blocks, but I took out the testing aspect. You will not be tested on origin or insertion. Yeah. So I didn't mean it that way. And I debated about that for years, and then I started asking to do it, and then all of a sudden you get people going, "Hey, we agree with you." Because I like to teach compartments, and if you can compartmentalize muscles, you can figure that out. But what I did is I took them out finally, got it out of the syllabus, and as a physical therapy assistant, life PT, some of y'all do a lot of musculoskeletal stuff. Origin and insertions matter when you're learning muscles. It really helps you to work through questions of what they're doing. But on the average day in the clinic, maybe not so much. But in here, I taught it once, and it didn't go well, I didn't think. And I just took out all the origin insertions. I didn't even discuss them. That was a terrible idea in hindsight. So I put them back in the slides. So the slides are going to have all of the origin and insertions in them. So when it comes to test day, I'm not going to ask you what's the specific origin. All right? If there's any type of exception done along the way, I'll let you know. But that should ease your mind. For those of you who've never studied origin and insertions versus those that have know that that's a huge break in studying A&P I of musculoskeletal. We can debate whether they should be out of there or not at a later time. Okay, so all of the material in this first block applies to 5, 6, and 7 exams because it's the terminology, it's the setup, it's a review of what you've probably seen before, getting us up to speed. And because of that, because I want you to have those words and terminology in your mind, I go back and take a question out of this generally for test 6 and 7 also. So, and I'll remind you before those tests that we need to look over these first 39. Okay, skeletal system. When we look at the skeletal system, you talk about, well, there's 206 bones, unless you're like a child, an infant. Infant technically has more bones because they have growth plates. Right. When we divide them up, we're going to see we have the axial skeleton, the appendicular skeleton, And just a visual representation, we will go through the different numbers and types of bone later, but when you look at the axial skeleton, we're just talking about the head, neck, and thorax, right, spine areas. And then the appendices, or your appendicular skeleton, is what we kind of consider our arms and legs, upper and lower extremities, and the bones that attach them to the axial skeleton. If you start to label and look at types of bones, they got really in depth in this, and they found there's long bones, short bones, flat bones, sesamoid bones, irregular bones, even sutural bones. And so I have a slide on each of these to just kind of understand why they classified it that way. And if you look at a long bone, like a femur or a humerus, it's always going to be longer than it is wide, and it's going to have a shaft or a diaphysis, and then the epiphyses on each end, the proximal and distal parts of it. So if you looked at a cross-section of like a femur, you'd see that the shaft is mostly compact bone. There is a little bit of spongy there. But the real spongy bone part of long bones is in the epiphyses, the ends. And we used to have a cross-section here, but I don't see it over here. And that's the way they're set up. If you look at short bones, the best example is going to be the carpals. You look at the wrist bones, and they're nearly equal in length and width, so kind of like a die or dice, even though they're not really shaped like that. That's how the book describes them. So they're going to have spongy bone, except for on the outer sides. Picture a dice having a hard exterior, and then inside you have that spongy bone. I put a note there. The pisiform is a sesamoid bone. We'll get to that when we get to the upper extremity. Flat bones, you always think like the skull, but the sternum, the scapula, they're all types of flat bones. And when we look at them, they're generally going to be concerned with or used for attachment, large attachment areas for muscles. Once again, they're going to have a very thin layer of compact bone with spongy bone in between it. And if you take the skull apart, I'll keep this over here because I made references more today as we go along. But if you take the skull off without breaking it, this one's not very good. You can see a little bit. You'll see some kind of dimpled areas, and that's because the spongy bone's in here and the compact bone is on each side. And that goes back to how it's formed through that membranous ossification, where you have all these membrane centers. And then we have sesamoid bones. You get a little more detail on sesamoid bones, but really, sesamoid bones, we know like the patella is a sesamoid bone. It's inside the patellar tendon, and it provides additional capabilities that normal tendons don't have. Like if you have a lot of stress on a tendon, or you're changing direction, in other words, providing a more of a mechanical advantage, the knee's the best example. There are other sesamoid bones, and people can develop additional sesamoid bones in the body. They'll form within these tendons if there's too much stress on them. You don't see that always, but I've seen several like ankle x-rays and things where you see this little, what's that little bone? Is that a fragment? And it's like a sesamoid bone that's in there. You can tell by how rounded it is. And then sutural bones are only found in one area, and a sutural bone is not the same as skull bone. I think I described this already once, I may not have, but we have the sutures that we're going to learn of the skull. I'll look that later. And if you look at these sutures and how they're formed, sometimes an extra bone is in here, and they call it a sutural bone. So every person in here may or may not have a sutural bone, could have more than others. It's just you had extra ossification centers, and so what we're talking about is here, we don't generally see these. Generally, you just have this sagittal suture and then your lambdoid suture that comes across. They did all the naming of these bones, Luckily, they didn't give us any crazy names yet that we've seen, but we will see crazy names. Then they got tired, and it was Friday before the 4th, and they went home. And they just decided, hey, all those other ones look like they're going to be tough to name, let's just call them irregular. And so when you look at vertebrae, your hip bones, the calcaneal bone, they're all just considered irregular. So don't focus in on which bones have this layer of compact and this layer of spongy. All bones are really a mixture of spongy. The only time we really focus on it is thinking about long bones and the epiphyses having a lot of spongy bone because of red bone marrow, that kind of thing. But I know I mention it on every slide, but you can think of it in your mind for like testing purposes that most bones vary in the amount of compact versus spongy bone depending upon their location. I'm not going to ask you to kind of delineate that out. So there are a lot of ways to name and look at bones and muscles. We're going to start here with bone surface markings though. Every bone in the body, if we pick this up, we could actually, you probably did this when you took anatomy before, where they said, well, what's this? And what's this, right? What's this? And you're like, well, that's the deltoid tuberosity. And well, it serves a purpose. The only reason to identify things on a bone is because we're going to talk about what attaches to them, goes through them, whatever that might be. So we call them surface markings, and that's where we get our origin insertions a lot of times from. But if you have a depression or an opening, that's somewhere that's going to allow soft tissue to pass through. Processes are going to be projections, like a greater tubercle on a bone. And they're going to serve as some type of attachment point. Keep it in mind that when we say attachment, it's a bias having dealt with it so long. I can say there's an origin of the bicep. There's two origins of the bicep, and there's one insertion. But both of these are attachment points, we would agree. So a lot of times you'll say, well, the biceps attaches above the shoulder. Okay, well, we use the word attached. If you're not used to knowing, I say it's a bias because if you're not used to knowing it, when I say it attaches above there, I know that's the origin. That's just a given for me to say. But when you think about attachments, you should always say, well, is that the origin or the insertion? And that's why we're going to continually look at the origin insertions, because if I know the origin of the biceps is up here, and I know it crosses the shoulder, which you always want to pay attention to what joints it crosses, and it crosses the shoulder, it also crosses the elbow, which means it's probably going to have an effect on the joint that it crossed. And if I know the insertions down here, I know in most muscles, unless we're talking about like stabilizing something, most muscles, when they contract, will pull the insertion towards the origin. So that's the concept of why it's important to look at this. All right. I left, rather than break out a bunch of slides on this, I took a couple of this and on some other muscle naming slides. I just took it right out of your book and put it on here. These are important for you to go through. This is not a chart to ignore. When I said I go back and ask a question or something, it's going back to these. These are your definitions and descriptions of the words that we're going to use for 5th, 6th, and 7th exams. But we're going to hear these as we go through all of them. So if you say depression or opening, and I won't read every one of them, fissure, foramen, fossa, right, a sulcus, so a meatus, tube-like opening, fossa, a shallow depression. That's the definition side of things that I want you to get to. The examples over here, when you study this particular chart, we will discuss the examples as we go through the upper and lower extremity of the torso. And so we'll get those. If you need to know that name is associated with it. For now, I just want you to look at the marking and what's its description. In other words, a list of definitions, right? And it's going to help you later because when you're talking about muscles, bones, you're going to see names like, well, that's a condyle. Okay, a large, round protuberance at the end of a bone. Versus like a trochanter, a very large projection off the bone. I know you say, well, what's the difference? Well, it's a book thing. And they are named things in different areas. A tubercle is a smaller rounded projection. A tuberosity is a large rounded projection. Then they throw in usually rough. Makes more sense as we go through them, but start learning these definitions. Alright, the book that we use spends a lot of time on levers, levers, seesaws, and trying to explain to you. And I took this down to just one slide. And I didn't worry so much about the lever. When you look at a lever, you're going to have something that has effort, you have a load, you have a fulcrum. So the effort, if I'm going to lift A&P, I'm going to lift this, I set it in my hand, I'm already, well, from gravity alone, right, I have an effort, or a load. Your hand's out there. You put something in your hand, that's the load. The fulcrum is your elbow, and the effort's coming from, let's just say for now, your bicep. And so we're looking at pulling the insertion towards the origin. Right? And they spend a lot of time making sure that you understand what a lever does. And the fact is, if we took like bicep insertion and we moved it further down the forearm, we cut it and sewed it back down here, it would take less effort to do that. Who cares? We do care, because in rehab they do that kind of stuff. In rehab they take muscles and move them not only to flap areas to cover the skin, but they also move some tendons to create more advantage for people. But when I say who cares, it means for us, for this next week and a half, unless you go into that, we don't really care about understanding every little part of the lever. So we're going to see a lot of ways that they name muscles. Important because when it comes down to, I hate when I say things this way, but when it comes down to testing, there's nothing worse than reading through answers or reading through a stem on the question and you don't know any info about what's being asked because you don't know the names, right? So the way they name muscles is going to give you, like, sometimes the name tells you the action. Sometimes the name tells you the origin or insertion. There are all these different ways, and once you learn those, it's kind of like, to an extent, looking back like we did tracts. Spinothalamic tract, ascending. You're going to see the same thing happens with the way that there's a lot of different ways they're named, but it helps you, especially if you're trying to rule out something on a 5-question test. So I'm telling you that up front because if you're not familiar with these words, then it won't help you on like an exam because you don't know what you don't know. Okay, so we'll look through. I'm not going to read through that. We're going to go through each one over the next 20 slides or whatever. The first way you can look at naming them is arrangement of their fascicles. Remember, fascicles are found as part of muscles. And so if the fascicles are parallel to the longitudinal axis, they're pretty much straight, and they will terminate in flat tendons. Those are called parallel. If it's fusiform also terminates into these kind of flat tendons, but the muscle belly itself is going to be a larger diameter. But the fibers themselves, the fascicles, are still pretty much parallel. Fusiform or football shape, or BP cup shape, the ball on the cup, you know. We also have circular arrangement of these fascicles, and that's going to be called the sphincter. I probably should take it out of my slides one day. You do hear them refer to this as squeezer muscles. It just makes me laugh. I leave it in there for me because I'm like, if I was still in high school, one of my buddies would be named Squeezer. I just never thought of it back then. Never thought of it. Maybe it would have been me, who knows? But we'd have known that name. Circular muscle fibers, circular, sphincter. Triangular is where you have your fascicles spread over a really broad area, and they're going to converge on one central kind of thick tendon. So if you picture pectoralis major, right, that pec muscle that's out, this large, broad origin, and coming out to insert. Yep. Pec major would be a great example of one of those. And then 3 other ways we can look at fascicles. You can have unipennant. So unipennant fascicles are very short in relation to the total muscle length. So you're going to have these muscle fascicles, and it's not depicted well on here because you're going to have most of the time a very long tendon. All right, if we, I don't know that I need to grab this. Your upper extremity is a great place to see that because if we look at the forearm muscles, the bulk of the muscle of your forearm is here, but the tendons are very long. Right, so that'd be a unipennant type of muscle. That's what they're trying to say. And you have a lot of these, but when you get down to the wrist, it's mostly tendons. I just needed a hand for that example. Bipennant. Bipennant has a central tendon with fascicles coming off of each side. So nearly the entire length of the muscle, these come off like this. We'll see bipennant, and I'll reference it again when we look at like moving your fingers. There's muscles in your fingers that are bipennant, and so when you try to move like just your pinky or your ring finger, it looks why other ones move. Because there's a bipennant muscle that's going half and half to each one. I'll show you that in the upper extremity, but that's why you can't do that very well unless you really focus on that. Bipennant. And then multipennant. Multipennant means you're going to have these oblique fascicles and tendons that kind of come off in 3 different directions. Multipennant. I didn't put pictures of all this on here because we're going to get to it, but like a multipennant would be like a deltoid. A very large deltoid that sits over the shoulder. And if you look at the deltoid, I should have kept the other way up. If you look at deltoid, it has fibers that go all the way down and insert on the deltoid tuberosity there. Well, as it does that, it has anterior fibers, it has posterior fibers, and it has middle fibers, and they all do different things. Like the anterior fibers are going to help you to flex, posterior fibers help you to extend, and you go out to the side in abduction. So the deltoid is a multipennant. They can do multiple actions because of that. Then we get to where I just left the rest of this in charts. We're going to look through some of this. Hopefully you see the value. Is when we look at characteristics used in A muscles, I left them all in here. Direction. Rectus means parallel to midline. You have oblique, it's diagonal to midline. So you see words like external oblique coming across your abdominal region if we're looking at there. I like to look at the size. They didn't do us any favors with size in the way they name muscles. Remember, I wasn't there, so don't blame me. We could figure out that we have, well, there's minimus, smallest, okay, I like that. Medius, the intermediate size, okay, I get that. Maximus is the largest. Now, I'm fine with all 3 of those until we keep going. Because then they went, well, wait, what if it's not the smallest, but it's short? Oh, let's call that brevis and longus. Actually, they did that probably because a lot of muscles have a brevis and a longus. Actually, if you have a brevis, you're going to have a longus. Peroneus, brevis, or fibularis now, brevis, fibularis, longus. But then they didn't stop there. They said, well, what if we have one that's the very longest? We'll call that longissimus. And they said, okay, well, what's the largest? Maximus is the largest. Okay, then we have one just small, and we'll call that large one Magnus. Major, larger. Minor, smaller. See what I mean? I'm like, my goodness, can we not get a consensus here? But all these muscles are named using those, and that wasn't enough. I saved it because at the end of the day, they got done, and they're like, okay, who named that gluteus maximus? Because I found a muscle that's much larger than that. So what are we going to do now? He said, we'll call it fastest. Huge. Okay. I think if we got a committee together today, we could get a consensus and narrow that down to just 2 or 3 of those, right? Well, at least 3. All right, enough of that. Shape. Deltoid, trapezius, pisiform, gladius. Right? All of these are named for kind of what their shapes are. Like I said, you don't have to get the examples yet, but the examples are where they will come up. But start studying these charts so you understand what we're talking about. It'll help you out. Going on to continue naming, we could say, well, what about the primary action? Flexor. A flexor, like the biceps, if it's flexing the elbow, is decreasing the angle, right? So we're at like 180 degrees, and now we move it to 90, we've decreased the angle. An extensor, like the triceps in that situation, would be increasing the angle. Abductors, you abduct away, adduct towards midline. Levator is going to raise or elevate a body part. Let's pick out a few more. Supinator, pronator. And remember, it's still anatomical position. Everybody does supination and pronation like this, but it's still an anatomical. You're still supinating, pronating. Just easier to represent. It's also easier for me to remember because if I supinate, so I may have some more soup. Twist there. You're going to supinate so you can get that soup. You're not getting any more, but you can try. I'm amazed. Nobody knows cheers, but everybody seems to know Oliver Twist. Cheers. Oh. I'm like, tensor, rotator. Okay, sphincter, decreasing. They call it a sphincter. It's decreasing the size of an opening. What about number of origins? I prefer when they give me the number of origins too, and or they give me the origin insertion. So biceps, triceps, quadriceps, 2, 3, 4 different origins. And then you have temporalis, which is just naming a muscle based on what it's located by. And the last part here is origin and insertion. When it comes to testing and stuff, origin and insertions are the best because when you look at something like sternocleidomastoid, it's telling you it has an origin off of the sternum, off of the clavicle, and it inserts on the mastoid, sternocleidomastoid. So that gives you the origin insertion. And anytime you know the origin and insertion, we now can figure out, most of the time, the action. Right? Because the insertion's going to be pulled towards the origin. Alright, so get familiar with those, at least after micros. Whenever you decide to get familiar with them, get familiar with them. And you'll see them pop back out. Actually, the key muscles where we're using that naming, you're going to see them there anyway. I promise it'll help you. So just like we saw with the eye, most of the muscles that you use in the body aren't acting alone. It takes a lot. You know, you say, well, I'm going to do a bicep curl. Right? You're going to do this bicep curl. You think, well, now everybody works out more and they understand exercise physiology more than they used to. But if I do a bicep curl, besides the other muscles in my arm that we'll get to, there are other muscles that help with biceps. But are there any other muscles that are going to help biceps to flex like that? Yeah. You got to stabilize other things in order to do that? And sometimes those are the muscles that hurt more than doing the bicep curl, right? They're trying to stabilize either the origin or the insertion. And so no muscle really acts alone. But they developed tests, like you look for the empty can test, which they kind of debunked, doesn't work as well as they thought. But an empty can test tests for rotator cuff injury, and you take their arm out and push down, and if they have a rotator cuff tear, you can bring them down. They're saying now you're not really isolating that enough. Don't worry about that. Just for now, it works. Right? But the whole purpose is, why not just hold your arms up and push down? Why do they have you turn them down, right? If you can, it's because it helps to isolate supraspinatus where it doesn't get any help from the other muscles. Okay, so if it's the main muscle that does an action, You're going to call it the prime mover. When you say the prime mover, you would say the agonist. The biceps, in this case, we would look at kind of as the agonist. The antagonist would be the triceps that has to yield to that. Remember, if the triceps doesn't yield, it's going to tear. The synergist, by definition, stabilize nearby joints, and fixators stabilize the origin of the prime mover. Let's see how we can define those out to where we can remember them. Once again, you're going to do a bicep curl. I have to stabilize the elbow to do that. So that's your synergist. You use synergists everywhere, but let's just, kind of a simple example. You say, well, the synergists are helping to stabilize this joint. But up here by the origins, you have fixators that are stabilizing the origin to help pull that. So we're putting tension on this elbow so those synergists will tighten up, but you also have fixators. So it's just, they're doing the same thing, they're just naming them different because it's at the origin versus just a joint that it's crossing. And then we have our nervous system. We're going to hear this gentleman's name a lot. I guess it's a gentleman, I don't know. Hilton. Hilton's law is the observation that a nerve that innervates a joint also tends to innervate the muscles that move that joint and also tends to innervate the stem over that joint. So if you look at the musculocutaneous nerve, and I don't have an example up here, but if you were to draw that out, it supplies the elbow joint with pain and proprioception fibers. It supplies the biceps and brachialis, which move the joint, as well as the forearm close to the insertion. So what it's saying is musculocutaneous nerve is going to innervate the muscles of the arm, anterior arm muscles. And then it's going to go on to provide pain and proprioception to the elbow. And then it's actually going to provide some of the cutaneous sensation below. So it's doing all three of those. That's Hilton's law. And you see that everywhere. But if you want to think of it more simplistic, think Hilton's law makes sense because the body, you wouldn't want to have multiple different fibers, just like running a network system. Things are going out and feeding off of it. Well, they're just tying off of that same nerve to do that action for all those areas. It's the body's way of saving space on them. But what if those nerves are running through something, you get all these things? Entrapment neuropathy is sometimes referred to as neuralgia, neuritis, what we call a pinched nerve. Anywhere that this nerve runs through an area that can be pinched off, like an intervertebral foramen, can cause an entrapment neuropathy when those spinal nerves try to get out. And if that happens, you're going to have numbness, tingling that starts to develop, then pain. And if it goes on long enough, you would start to compress that nerve long enough, you can actually cause atrophy of the muscle that it innervates. You can cut off the blood supply. Right? Entrapment neuropathies are pretty common. Where you see them mostly, like in the upper extremities, you've heard of thoracic outlet syndrome. In the shoulder, you may never heard of it, there's supraclavicular neuritis. In the elbow, you ever heard of golfer's elbow, tennis elbow? Those are really called, ulnar neuritis, median neuritis, radial neuritis. You can have inflammation of any of the nerves that are close down there to the elbow. And in the wrist, we have the infamous carpal tunnel syndrome and ulnar neuritis. Only the radial and ulnar nerves go into the hands. Only the radial, ulnar, and median nerves do anything with the hand. We'll get to that. If you look at the lower extremity, you still have things that you've probably heard about. In the hip, you have piriformis syndrome, which is compression on the piriformis nerve. Compartment syndrome is where you're going to have compression on a nerve that's running through a muscle compartment. The nerve's inside of a muscle compartment, which has a fascial sleeve around it, and you start to bleed into that area. That's going to get very tight. It can only hold so much, and eventually it will start to compress on the nerve. Not to mention the blood supply. And the foot, tarsal tunnel syndrome, medial plantar neuritis, plantar fasciitis, deep fibular neuritis. All of these are conditions associated with nerves that go into the foot. Like I said, we're not going to discuss a lot of it until we get to those sections. I already said this. Numbness, weakness, pain. It's like falling asleep as a kid, watching TV on the floor. I don't know if y'all ever did that, and your arm goes to sleep. You're compressing the nerve on there. Since you've already had the circulatory system, we're just going to look at it as a whole. So whatever you do not study this next picture. Because we'll talk about the importance. I promise you this. Every circulatory vessel that we go over is going to be minimal compared to what you study in a lot of circulatory. But don't study whole charts and whole bodies of it, because we're only going to be asking questions about like main vessels in the arm or forearm when we get to that. All right, so for now, this is just a representation of circulatory paths. Because you have systemic, pulmonary. I don't know if Ruggiero discussed it. The routes for blood supply in the human body are generally parallel as opposed to series. And all that means is every organ gets its own blood supply. When you have branches that come off of the aorta, versus if it was in series, it would go from the heart to the stomach, to the liver, to this, to that. And if you blocked it off at any point upstream, there would be a problem with all of those organs. But each organ gets its own blood supply, so that's a parallel system, which lowers the overall resistance. I'm kind of speeding through this, because I know you aren't really familiar with this at the moment, or you were, at least back when he tested you out. Arteries, arterial. If you don't know that arteries carry oxygenated blood, I just flashed back to my daughter telling me that instructor that was arguing with her about blood flow out of the heart or whatever. Arteries, arterioles carry oxygenated blood from the left ventricle to the systemic arteries, down to the capillaries. Of course, we have our ascending aorta, the arched aorta, thoracic aorta, abdominal aorta. This is an example of, we will come back to this chart, and I will point out specifically off of this, but I want you to know something as we go on. We'll see that one. Same thing with this one. Right? Great example, if here are all your major systemic arteries, and somebody's still going to ask, hey, when you study that whole thing, it's in your study pictures. Well, for the upper extremity, you got to know the upper extremity ones. Torso, you got to know the torso ones. Lower extremity, you got to, but there's not that many. There's not that many. It looks like there are, but I'm going to clarify. I'm telling this to the people who stress more than others. It will be very clear which ones you need to know as we go through. The veins, of course, deep veins are parallel with the arteries, and then you have superficial veins that are outside of that. In other words, they're close to the skin. All venous blood will eventually go back to the superior and inferior vena cava. There's your major systemic veins. Moving on for now. Venous comitantes, I like to say that like I'm from around the country. In a lot of areas, when you see a deep vein, and we picture one vein and one artery, that deep vein tends to actually form comitantes that surround that vein. And it's going to help us with, well, I'll switch. It helps with what's called the countercurrent exchange. Did y'all talk about that in circulatory? That as your deep veins are next to your arteries. Well, as the blood comes out of your heart and goes through an artery, it's fairly warm. But when it's coming back from the extremities, it's cooler. And as these wrap around it like that, the veins do, that's a countercurrent kind of exchange of heat. So oxygenated arterial blood that's going out to the extremity is warming the blood that's coming back towards the heart. Not only that, as the artery expands, each time. It's compressing on the vein and helping to move blood back towards the heart. That's called the arteriovenous pump. Right. Haven't talked in a week or two. Which we also will see we have musculovenous pumps. If an artery is inside of a muscle and you tighten, or an artery in a vein, so if the vein's inside of that muscle, you're tightening that muscle, it's helping to push blood back towards the heart also. And then we have our myotone, remember dermatome, all the regions of that one skin area that enter the spinal nerve at the same level. Right? Well, all muscles or parts of muscles receiving innervation from one spinal nerve, we can track all the way out to what we call myotome. Right? So if you look at the musculocutaneous nerve, it innervates all three muscles of the anterior compartment of the arm, and so that would be, we know exactly where they enter the spinal cord, that would be a myotome. And recurrent is running in the reverse direction. As the vagus nerve comes down, it crosses, it actually comes back to the larynx. Remember, it's recurrent. So that's it for the opening / introduction. Just like I said, get familiar with those terms so you know what we're talking about. Now it's time to take a break. Go get some more coffee. Early lunch. Maybe I'll clear my throat. Yeah, please. What you get for thinking?
Colonies, pink colonies versus this.
Trying to get ahead in life.
It's horrible. All you do is say, like, it's one of the vaccine or not.
Dude, I don't like it. I was doing the same. I was like, okay, this one's light pink, this one's pink and nasty.
within 30 seconds, I had like 2 they were too small. One was too small to keep. But then, yeah, I got 8 snapped full. I have 6 now. And within 24 hours, there's fucking ocean and 4 day. Alright, just let's see. They're done before this like fucking right out of all this. Man, my boy fucking taking out some tears or so.
How you feeling, my boy? No, I mean like out here. That was on Friday, right? Oh yeah, so recorded. Yeah, dude, I went home. I was like, gosh, so I was so exhausted.
No, yeah, I'm good on that.
Really? All we can do is
Yeah, I see.
I usually don't
I went home. I studied for like 40 minutes.
Oh, I don't think we did like we were doing an A&P one gases. One of my 60 slides around. There was a slide that we used tic-tac-toe. Like
You're already back. Yeah,
I thought that told you if it's either metabolic acidosis or respiratory acidosis. You know what I mean? So we just 30 to 60 seconds. So this is like so we're writing for you. Sometimes everything. Yeah. So if that makes you feel better, it's like so far this like I would
waking up and I feel like
it's like 30 I want to say the over under on 42 minutes. That's what I'm it is, but I see it. I'm a degenerate gambler, so. Exactly. But yeah, hopefully that makes you feel a little better about
Yeah. So,
Yeah, I'm hoping like not bad. Yeah, that's
So they basically said,
how do you test that?
so the game and he just randomly
first it wasn't
Definitely my number one.
Simple as that. Like, I don't want to work. It's definitely
he took the big concept here in smaller parts.
what's missing, right? Yeah, like most of the effective so probably switch up something like that. It makes me wonder when they say that, like what's going on default. But it's, he has to ask about parts of this, like, he has to ask about questions about, just like, you can't really not test on the surgeon. I've been doing this since, I think it worked out in that health situation. Like, it worked out given the situation. So that It'll be good.
I'm not saying I'll stay.
Alright, here we go. Here. Ready to go. We were up there talking about the weekend. And everybody had crazy weekends. That was in Port A. I didn't have a real crazy weekend. But Port A was crazy. But when I go down there, I don't go out to eat on July 4th. You were down there too? Where'd you stay? Makes sense. A lot cheaper. My son was staying over in Rances because he didn't come down with us. He's older. And what was? Oh yeah. I only went across not the ferry once. And that was it. For some reason my wife booked something I didn't want to do. Your wife or your spouse ever booked something for you that you heard? Yeah, okay. And then I'm like, we're gonna do what? Wait, it starts at 10:30 at night, and we're gonna do what? And she had booked Glow Row kayaking. So about a mile up from the ferry, there's those houses that people may not realize, but there's a couple of houses that are kind of place. And we're going all through where the tide's coming in, and we're pretty much on the ground, kayaking around. It was one of the coolest things I've ever done. That was cool. Fish jumping in the boat, shrimp, crabs around. It's very interesting. If you never Glow Row, you should try it. It's just a clear sit-in kayak, and it wasn't very much. There were some people dying. I'm like, y'all need to work out or something. I'm like, we're just kind of strolling along. And they're like, the lady ran into me 3 or 4 times. I was about to tell her, just get away from me. Get away from me. I'm not going to say. How can I say that and be nice? She weighed a little bit more than her husband. But her husband, who was clearly about 100 pounds less than her, taking the domineering role. The person in the back in a canoe or kayak, and the 2-person one, is the one who's really in control of steering and kind of guiding you. But when your boat's like this, that's a little hard to do. She'd start to paddle, and he couldn't counteract it enough. He'd come right over here. And she would paddle on one side a bunch. And that's 2 sides. Was that did I say that appropriately, or was that rude? I had to give you an idea of what I'm talking about.
Big bones.
All right, regional anatomy of the head and neck. Here we go for starting. We're going to start with the skull, kind of work our way down and in. One of the harder parts about the head, neck, and torso portion is when we get inside the head. I'm going to be looking at where things like cranial nerves go through. how do the cranial nerves get to where they need to go? What type of frame and opening allows that? And I'll show you the ones that we're expected to know. But the scalp itself has layers. You have 3 layers that are kind of fused together, and you can use this way to remember it, where you have scalp or skin, and epithelial tissues, right there over the top of that. And then you have our cutaneous layer, right? Connective tissue, that's your hypodermis, your subcute, right? And then aponeurosis, which is, if you look at the clear white covering, like on this example here, this is called an aponeurosis. We're going to see that muscles tie into that for their attachment point. That's the cranial aponeurosis, all this white area here. It's a broad attachment point. And then below that you have, deep to that, you have loose connective tissue, which is the danger, Will Robinson area we'll see, and then the pericranium bone. So if we were to show just a picture of this, you have skin, you have some connective tissue underneath that, then you have the aponeurosis, then a loose connective tissue layer, and then the pericranium that overlies that cranial bone. Those first 3 layers of the scalp are fused together. And so if you take your hands and move your head back and forth, right, you actually can move those 3 layers. If you were to go in like Indian, let's say, so we're not derogatory towards Indians, anyone in the world tries to scalp somebody, they're going to run that knife along there and peel back those first 3 layers. Just saying. I don't recommend doing that to anybody. Oh man, it just reminded me. I'm driving out to work today, and I found something that made me want to shoot somebody. On the way out down our road, there's a big trash can down there. We have a community trash can. And as I'm driving down, there's a box on the side of the road, about 100 feet from the trash can. And I get out, what's in the box? A fawn that I didn't open completely up, in a trash bag. It's like an open top box. And inside is a trash bag, a little deer in there, and I had to get to work, but it looked like it had been skinned. I'm like, who would skin a fawn? Here, I'm looking for them. Look, I wish our cameras were working up over there by the dumpster. I can go find them. That's just rude. Who would do that? I have an idea. No, I have no idea what it is. Okay, scalping reminded me of that, yes. Loose connective tissue under those first 3 layers. It's a danger area because it's like a sponge type of loose connective tissue, and if you get an infection, it can spread very rapidly across the cranial area using that loose connective tissue layer. And then you have the lining of the bone itself called the pericranium. We'll get into what areas we call the calvaria here soon. So the skull has 22 bones, and it consists of what's called cranial bones and facial bones. Some of these will be in those categories when we look at it. So the skull itself has a large cranial cavity. We're going to store our brain. But we have smaller cavities like the orbital cavities, the nasal cavities. The nasal cavities themselves have the paranasal sinuses. These are openings within bones and that help to basically lighten the skull, but also sound resonation. You have your sinuses in there, there's sinus tissues. If you look at movable bones of the skull, it would include the mandible. Now you can move your jaw, and you can move your ossicles. Every other bone of the skull does not move, just your mandible. And you can yak all day long. And then little bones inside your ear, the ossicles, only ones that move. That's why the main bone that we hear about with the skull that has any problems with like arthritis and things is the temporomandibular joint, because your mandible is moving. And then the bones of the skull are held together by sutures. They're immovable. And over time, we say those futures will start to go away. You know, they fuse after you're an infant, and then eventually they will disappear altogether. They can actually, they will fuse. I had to stop because I was thinking of floods and things, and I don't want to talk about time. You can tell the age of a body though by one of the ways is the skull bones that are fused and how long they fused together. Okay, neurocranium. The neurocranium is the portion of that contains our brain itself. So if you take the skull, and there would be a cerebrum in here, so everything that surrounds the cerebrum is your neurocranium. So if we open this up, we're going to have, this is called the calvaria, we're going to have these bones, and then the bones that are in the base of this, that form the base, the bottom, are all part of the neurocranium. But because of that, some of those bones are also going to help form things like the orbits. And so we wind up seeing these different lists because of that. But when you say brain box or neurocranium, you're specifically talking about, think about any bone that could like touch the cerebrum. Think of it that way. The facial skeleton out here in the front is the visceral cranium. Because your visceral organs are all out there. And you talk about smell, nasal cavities, your mandible, maxilla. All of these is your all of these are your facial skeleton. When we look at the neurocranium, like I didn't give it names before, but taking this top part off, your skull cap, or if you're wearing a skull cap, is your neurocranium, and then the bones in the bottom, actually I called it the base, but it's called the basicranium. And so we're going to look at what bones make up each different area so that we can see what goes through them and where. Leave that apart. 8 cranial bones, 14 facial bones. So the cranial bones, by definition, are going to protect and house the ear ossicles. They're going to provide an attachment point for muscles from the neck, for the facial muscles. And so when we look at cranial bones, mostly what we're talking about is what we call like these skull bones up top associated with the calvaria. But there are also other bones that are considered cranial bones. Facial bones, like our facial skeleton, protect a lot of our special senses. And of course you have an opening to your nasal cavity, your mouth. So here's your cranial bones. And this is probably, for a lot of you, about as deep as you studied in anatomy before you got here, is they say, well, there are these cranial bones. We have 8 of them. And you have 1 frontal bone, because the suture in the frontal bone is going to fuse before you're like 6 years old. And so that fuses. So in blue, and don't study with cranial bones, just telling you this up front, don't study colors. Every book you look in, I'm saying this, you know I'm saying it because people have. Every book you look in, a lot of times the colors are different. I think most of mine are the same. It doesn't matter what color it is, it's still the frontal bone, right? So in blue there you have the frontal bone, and then just behind it and on each side you're going to have 2 parietal bones, and then you're going to have 2 temporal bones we see there in purple. We have 1 occipital bone that's in the back. In green, and they made it very large on this picture for representation. It varies how big this is. This green area is called, it's on each side, and it's called the sphenoid bone. And so on each side of the skull, you can actually see only a portion of the sphenoid bone. We'll talk about its importance here in a second. And then you have the ethmoid bone that is up there back by the nasal cavity. It's going to be found in here. And as we go through these, the picture will make more sense in how we orientate. But those are our main cranial bones. Here's another picture, which I purposely changed the color on that one. I use an old picture because don't study color. That's an unfortunate way somebody missed the question once. Otherwise, Well, I didn't think it was the frontal bone because it wasn't blue, and that dumbfounded me. But I felt for him. I didn't give it back, but I felt for him. I had sympathy but no empathy. No. That's not fun. Okay, there's your bones. You'll be able to use these pictures more once we get through a lot of the information. Because we're going to go through each one and say, well, here's the frontal bone, and what are the general characteristics that we need to know about the frontal bone? It has what we call the forehead, is formed by the frontal bone. The roof of the orbital sockets is going to be part of the frontal bone. And then the anterior cranial floor. When you say anterior cranial floor, we're looking back in here. So that's going to be a bone that's probably associated with our basicranium, right? Other areas on this bone, you have the supraorbital margin on each side. And inside of these bones, in here, you're going to have frontal sinuses. And so that's depicted over here. Right, your frontal sinuses are hurting you. Your frontal, are one of the sinuses that are first to become infected when you have a sinus infection. The parietal bone, we don't have to talk about as much because there's not really anything going through it, it's just there. There's two parietal bones, one on each side. You see them there in whatever color that might be, peach. But the temporal bone is where we really get busy because the temporal bone is on the outside. It has the tempora, or the temporal portion, but then it projects in. It's a large part of the basicranium. So if we go back to that skull, this thing stays together. If you look at the temporal bone on each side, and then when you flip it, we would actually see that a portion of that bone comes in on each side. That's called the portion that projects in is called the petrous portion. And we'll hear that because we're going to talk about what goes through there. So the temporal bone, I'm going to come back up here and show you it. You have a zygomatic process. Now we haven't made it to the facial bones yet, but you have a zygomatic bone. The zygomatic bone has a temporal process that connects with the zygomatic process, the temporal bone. It forms what we call our cheeks. But that's the zygomatic arch. You have an opening in the temporal bone here called the external auditory meatus. So that, right, our ear canal is going to go through. You have the mastoid process. On each side, you also have this projection of bone called the stylomastoid, or styloid process, sorry. And then we're going to have to look at a different view, but you have the stylomastoid foramen, the mandibular fossa, and petrous portion. I labeled out beside these. Right, the stylomastoid foramen is where cranial nerve 7 goes through. When you look at mandibular fossa, I didn't note that on here, but this, where the mandible meets the temporal bone, is called the mandibular fossa. Collectively, that's all called the temporal mandibular joint. That's the mandibular fossa. And in the petrous portion, we're going to see cranial nerve 8 and some arterial and blood vessels going through. All right, so we get to this picture. If we look at the purple portion that's projecting in, like I said, that's what they consider the petrous portion. Going through that are two very important vessels. Right? The internal carotid artery and then the internal jugular vein. And so if you follow the labeling, this is called the carotid foramen. And then behind that, posterior to that, you have the jugular foramen. Now I didn't mention it on here, but we're going to discuss blood supply to the brain. And you have an external, we know we have an external carotid artery and an internal carotid artery. Right? Well, the external carotid artery goes out here to the external portion of the facing head. But when you have to reach the base of the brain to the circle of Willis, you need to go through this temporal bone. So that is the internal. You may want to write it there if you want. We're going to talk about it later, but internal carotid artery goes through the carotid frame. Just so you don't come back later and go, I didn't know if it was external or internal. Well, only the internal carotid needs to get to the base of the brain. The external doesn't. Okay. Occipital, that's it for temporal for now. The occipital bone, everything we see back here in yellow, has a large opening in it called a magnum foramen or foramen magnum. It has occipital condyles, which are found here. I'll just put a, this is one occipital condyle, here's the other. If you look at the, you can see them on here. If you look at the way the base of the skull sits on the first cervical vertebrae, the atlas, the occipital condyles that are found here are going to articulate with C1. So they're called occipital condyles. We'll get back to that too. And then you have the external occipital protuberance, which is found here. You can all feel that on your own head. That's where the drill sergeants put their strap to the hat they wear, and I call it the drill sergeant's bump. But that bump back there is called your external occipital protuberance, and it is an attachment point, as I wrote here, for ligament nuchae that we'll discuss later. But if you bend your head down, you can actually feel there's a rather large ligament that's attached to that. There's been studies that say that, not in our lifetime, but eventually we're all gonna, they've seen people developing spurs. Anybody with plantar fasciitis ever developed a bone spur? Plantar fascia pulls on your calcaneus long enough, it'll make a heel spur. We've all kind of heard of those. They're saying the same things happening to the external occipital protuberance because of how much time we spend looking down at phones and computers and things. And I read that, and I don't believe it. Because before, when the people who wrote the books, and what am I trying to say? The people who studied anatomy originally, and they had all these books, they didn't have a computer. What do you got to do the whole time you're reading a book? I'm like, I'm not buying it. I'm not buying it. But they have seen people with heel, with like spurs that come off of there. I guess, I don't know, maybe they're using their phone more than me. But I can't imagine they have their head down more than like let's go study some monk scribes or something. They were looking down there. Y'all aren't with me on this. I'm not buying the study. Okay. Other thing on here is superior and inferior nuchal lines, which are attachment points for muscles. Right. This skull's, for reference, is flipped like this in the picture. Right. But if you turn it back right side up, you have your drill sergeant's bump, external occipital protuberance, and then you see some kind of raised lines. Those are the superior and inferior nuchal lines. Then we have the sphenoid. The sphenoid's here in green. The sphenoid is called the keystone bone. So you can't always see it because it's an interior type bone, but the sphenoid articulates with every other cranial bone. So it has an articulation. It touches every other cranial bone, and it's kind of winged out. It has wings to it. So this is all the sphenoid in green there. And then it has some processes. I'll have to show you from the side. It has some processes that project off of it or down, and they are attachment sites for your jaw muscles. I'll show you in a second. So if we were to find the sphenoid, what we're going to see is it has greater and lesser wings. This, now remember on that other picture it was very big. Here it's depicted very small. But on each side of the skull, there's always a portion of the sphenoid you can see here. And that's really from the greater wings. And so keep that in your mind. The greater wings going out there and picturing the sphenoid back there. Then we go to this picture that's holding it up. So that portion that's on the outside of the skull over here is this. Part of that wing. And then the lesser wing is going to form part of the orbital socket also. So these greater wings form what they call the anterolateral floor of the cranial vault. And in the middle of them, you have this kind of squared off area that houses the sphenoid sinuses. So now we have maxillary sinuses, now we've got frontal sinuses, now we're adding in the sphenoid sinuses. The processes coming off the bottom of that bone are called the pterygoid processes, and as we look at the muscles that move the jaw, we're going to see that we have lateral and medial pterygoids. So along with like temporalis and masseter that help control chewing, moving the jaw, these are going to be attachment points for muscles that help with that. And we got to look, that's it for looking at the main structural parts of it. So now we want to know what openings, if the sphenoid is such a big bone in there that connects all the other bones, these things got to go through it. So you have multiple openings in this bone that we name, and we need to know what goes through them. Right, so the optic foramen is found here towards the top. And guess what goes through the optic foramen? The optic nerve, THI, which is cranial nerve 2. And then we have fissures. We have a superior orbital fissure and an inferior orbital fissure. We're only going to look at really what goes through the superior orbital fissure, because that's a passageway for all three of the cranial nerves innervating the muscles, extrinsic muscles of the eye. Ocular, motor, trochlear, abducens, 3, 4, 6. So cranial nerves 3, 4, and 6 get to the external eye muscles by going through the superior orbital fissure. Now this picture, it's a little harder to see than this is the superior orbital fissure. I tried to circle it there. This opening is the superior orbital fissure. It's just harder to see in this view. And B1 goes through there. So cranial nerves 3, 4, 6, and B1 go through the superior orbital fissure. Well, what's B1? It's trigeminal nerve, but it's what branch? Ophthalmic. So that makes kind of sense. Maxillary branch of trigeminal. We're going to break the rest of these down by what they call standing room only. When you look at the superior orbital fissure, V1 goes through it. When you look at the foramen rotundum, which is just behind that, that's your room. Cranial nerve V2 goes through there. And then here we have foramen ovale. And foramen ovale is where V3 goes through. That's where this comes from. Now there are more openings, right? So make sure you're familiar with labeling the openings that I talked about, though. There are more openings that we're not going to discuss every single thing, but those are 3 that tend to come back up. Right? Because there's a foramen spinosa and all these things. If I don't mention it or box it off, don't worry about it. When you studied endocrine, we found out we had a pituitary gland. That pituitary gland lies in an area called the sella turcica. And so you have 2 sides to that, these tuberculum cellae, dorsum cellae. I'm lining those out. I don't care about that. I care that you know this. The hypophyseal fossa is in the sphenoid bone. You probably already know that. That's where the pituitary lies. That whole area is called the sella turcica, but I don't care if you can name the ridges on each side, because you'll never think about it again. All right, our ethmoid bone, not as busy as the others, but the ethmoid forms the anterior portion of the cranial floor. This is part of our ethmoid bone. And the supporting sides of the nasal cavity. You have projections that come off of this. You have one that's called the crystalgalia. That is here. And if you were to continue drawing that, if we look at a brain, the cerebral hemispheres, remember in between the cerebral hemispheres we have an extension of the dura mater, right, the tentorium cerebri, it attaches to the crystal galea as it goes down through. The tentorium cerebri goes between the cerebral hemispheres and attaches to the crystal galea, completely separating, except for our tracks that go back and forth, completely separating those hemispheres. I said tentorium cerebri, Oxford, sorry. It's tentorium cerebellum. And then the olfactory foramina, we have to really kind of enlarge them, but in the middle of this bone, you have these areas here that look like they have Swiss cheese holes in them. That is where the olfactory or cranial nerve 1 nerves go through. That's the same thing we find if you rotate it back to where how it is, and they're going through the olfactory foramen up here in the ethmoid bone. Just lateral to each area where we see the olfactory foramen, we have the lateral masses. And they contain the ethmoid sinuses. And then you also have a perpendicular plate that we find right here. So this is the crystal galea, and that helps you orientate how this is sitting, superior and inferior. You look to the perpendicular plate, which is also part of the nasal septum. And then the last part, you have two projections that come off of the ethmoid bone called the superior and middle nasal turbinates, or concave, or nasal turbinates. And they participate in smell. They have the ability to increase, you breathe in through your nose, it can warm the air, but the turbinates that are lined with your sinuses also, but the turbinates cause the air to swirl within your nose and expose it to mucus or to receptors, whatever it needs to be. So turbinates, or the nasal concave, create turbulence in there. And we find them here, where you see, this is the superior on each side, and this is the middle. I'm going to mention it here and I'll mention it later. There is one more set of nasal turbinates, and those are the inferior ones. They are not part of the ethmoid bone though. So we'll talk about where we find them later. Part of your facial skeleton, really. So that's, remember we were studying the cranial bones, and now we're getting to the visceral cranium, or the skeleton of the face. And these are the bones. Remember, we have 8 cranial bones, but we have 14 facial bones. And so you have 2 nasal bones, 2 maxillary bones, or maxilla, sorry, zygomatic bone, you have 2 on each, 1 on each side, 2 mandibles, sorry, 2 mandibles. I meant to say lacrimal, but 2 lacrimal bones, then you have your mandible, and then the palatine bone you have 2, and then the inferior turbinates you have 2, and then the vomer is 1. And so if we look at this picture and kind of pick those out, I'm going to start with the lacrimal bone that we find here. Reason for that is you see that kind of, I drew over it, but there's a kind of a depression in that bone. That's called the lacrimal fossa. That helps you to identify, when you look at the picture, which bone that is which. Out here we have our nasal bones. And then we have our, our perpendicular plate is going to attach to where the vomer comes out. In yellow we have our maxilla. In pink, we have the zygomatic bones on each side. The palatine bones make an appearance in the orbital socket, but I'll show you on a different picture. And of course, we have our mandible. And then down here at the bottom, remember we have superior, middle, and now we have inferior nasal turbinates, which are separate bones of your own. So that's the whole list of them. You can look at it in different pictures and kind of see those as we go through them. Like I said, I'll come back and show you the palatine bones because they sit kind of funny in there. So we're going to start out saying, well, the maxilla. The maxilla and the mandible both have sockets. The sockets are termed alveoli, but previously we learned, you're like, well, wait, that's the gomphosis. Now the joint that's formed between the tooth and this alveoli is the gomphosis. And that's a joint. When we're saying just the bone has sockets for those teeth. Right? So those are called alveoli. That way they can confuse you between facial skeleton and lungs. You aren't studying respiratory yet? What do you call the little sacs in your lung? Alveoli. Right? Okay. Floor of the orbit. When we look at the orbit, and we're just talking about the maxillary bones, we're going to find that part of this bone is the floor down there of the orbital socket on each side. Right? It's attached to the rest of it. And then we see the last of our sinuses are maxillary sinuses. So we had frontal sinuses, we had sphenoid sinuses, ethmoid sinuses, and now we have maxillary sinuses. And then our alveolar processes, once again, are going to help hold our upper teeth in, or be a socket for it. The zygomatic bones are what we call cheek bones. So the zygomatic bones are the lateral wall of the orbit along with the sphenoid, but when we look at their connections, remember the zygomatic bone is a temporal portion that attaches to the zygomatic portion of the temporal bone. I didn't really discuss the whole socket with each of these because we're going to define out orbital socket on its own. Then you have the lacrimal and inferior nasal conchs. If you look at the lacrimal bones, I already pointed this one out, but they're going to be found here. So if you were to divide this up down the middle and just look at one side, you'd say, well, there's a nasal bone, then there's part of your maxillary bone, then there's your lacrimal bone, and then next to that, you have your ethmoid. As we go, if you were to touch your nose and kind of slide your eyes back, and you're going to try and massage those ethmoid sinuses. So we'll always look for that lacrimal fossa though, because it tells you where the lacrimal sac is, and lets you know which bones are. I think I've talked enough about turbinate. All right, looking at our mandible, our movable bone, we have what's called the body, then you have the angle, and in this portion that projects upward on the sides, lateral sides, it's called the ramus. And it has a couple of processes. This is called the condylar process, and this is the coronoid process. But the condylar process is going to be articulating with the temporal bone, right, at the mandibular fossa. In other words, that's going to create our temporal mandibular joint, those two bones. It has a couple of foramen in there. There's the mental foramen on each side, about right here, where the mental nerve comes through. Do you remember what mental means? Chin. So it's good to learn that stuff early. Your chin, so that's your mental region. So a mental nerve goes through there. The mandibular nerve goes through an area called the inferior alveolar, the inferior alveolar nerve goes through the mandible at the mandibular frame. It comes through here. And it is going to provide the innervation for this area. There's another one over here that's going to come in and provide this way. This is probably the inferior alveolar nerve. I left it on here because when y'all get to do dental anesthesia on each other, that's probably what you're going to go for. And they're going to have you trying to stick a needle in there and hit that, well, don't hit that nerve. Right? Block that nerve, and so you'll be numb, anesthetized along your mandible on that side. Something to look forward to. Once again, whoever's mind just thought this, Nobody's putting a needle in there on me. Yes, they are. You can't do one if you don't get one. It's like IV training. Can't do one, you don't get one. They're still talking back to me in their head going, I'm gonna be sick that day. Be calling in COVID. It's not that bad. It's not that bad. Unless you don't like needles, then it's real bad. Nothing like seeing the person next to you coming at you with that same way you're helpless. We're just making it worse, right? That's what my wife always tells me. Why do you make it worse? Kind of sensitize you to it. It's coming. Just tell me to shut up when I'm talking like that. Plus I've been dragging on and on. Palatine and Bulmer. Let's finish the facial bones out. When you look at the palatine and the Bulmer, the palatine's the one I said it's harder to see, and the Bulmer though, did y'all do respiratory yet? I can't remember. No. You're doing it now. No?
The next class will be respiratory.
When it starts. So you're going to see this exact same picture. We might even ask you the same question on each of our tests because we use the exact same picture. Everybody uses this picture. The Bulmer is this bone here. And if we go back to the ethmoid bone, this is where the nerves go through. So this is a part of the ethmoid bone. Remember the projection that goes down, separates our nasal cavities, is part of that bone, and it's called the perpendicular plate. And out in front of that, you're going to have septal cartilage. That's the movable part. It's also, if you think about where you get septal deviations, that's where this is going to occur. Right? If you don't know what a septal deviation is, that's where your septum gets deviated. It used to occur a lot more before social media. Now we have social media, you can say anything you want without worrying about getting your septum deviated. But some people, you read it, and you would immediately, if they said that to your face, you'd immediately deviate your septum. That's the whole problem with social media. Nobody's worried about getting hit in the face. No matter how you feel about what they said. L-shaped palatine bones make up part of the hard palate. So I'm going to have to show you in this kind of view. This is off of that 3D anatomy. And so if you looked at the hard palate, you're going to have a palate. This is two different bones. They are separated. And they're going to project up. So they call it like two backwards T, backwards L's, or upside down T's. But the point is, the palatine bone forms the hard palate, and then it comes up and provides a portion of the orbital socket. We can see the bottoms or the tops of the T's over here, if they were upside down. That hard palate area that is part of your palatine bone. Like I said, it goes all the way up here to the orbital socket. When we study the orbital bones, we'll look at that one individually. And then the nasal septum is what divides the right and left. I already said this. Formed by the Bulmer, the perpendicular plate, ethmoid, and septal cartilage. Get familiar with that picture just because it'll help you here and in respiratory. I know he uses the same one. So those are all the bones of, we say the neurocranium, we say the cranial cavity, where you're going to get confused. This makes a lot of lists, right? And you do need to be able to know, like, what bones are part of your cranial bones, which bones are part of your facial bones. But sometimes those lists overlap, right? So pay attention to that and where they overlap. Because we're going to go back tomorrow. I shouldn't say it out loud sometimes, but we're going to start here tomorrow. And we're going to see, I'm using this for my example of how you study it. We're going to see that we have an orbit. But have we already talked about the bones of the orbit? Yes. Because they're part of the other bones of the skull. But now we're going to specify, well, only these bones make up part of the orbital socket. And you're going to need to know exactly those bones and where they form in the walls and stuff that we'll talk about tomorrow when you get into ophthalmology. Or actually, when you get in, make it important, what about emergency medicine? Orbital fractures, that kind of thing. And so ophthalmology definitely makes you study NER, emergency medicine, the bones of the socket. But, like I say, so you can't just make one list here of all these bones. I mean, you can depending on how you study. But what I'm trying to say with all this is just keep in mind the list of what, because you wouldn't want to miss something easy like which of the following is a cranial bone. Because that sounds like all of them, right? Or which of the following bones is part of the neurocranium, or the basic cranium? Right? I need you to get familiar with those. Am I making sense? To delineate the differences. Not that I'm going to key in on it that much, just it'll help you to answer the things I do have. Okay, so we'll pick up there tomorrow. We covered a lot today. So, hope the rest of the week. I'll be back tomorrow and we'll still be talking about microproperties. I hope your studying goes well, and I know that it will. I've been here long enough to know it will.